Hi everybody, I'm Shailesh representing Team IHP AI Innovation. We're representing Inland Empire Health Plan based out of Rancho Cucamonga in California. We serve about 1.5 million Medicaid members. With that being said, let me get right into it. Imagine if Netflix only recommended the movies you watched last year and guessing your next pick from that same stale list. Would you pay $25 a month? Probably not. Now imagine your care is managed the same way, with outdated lists and late nudges. Healthcare has always been playing catch up. We built a multi layered, AI enabled HEDIS care gap platform that flips the model from chase and close to predict and prevent. You might be wondering, what is HEDIS? So, quick context, HEDIS is the healthcare effectiveness data and information set that measures quality of care for health plans. Think colorectal cancer screening, cervical cancer screening, bell child visits, and these are tracked yearly or on a different time period based on that quality measure. Health plans get paid millions in quality bonuses for hitting these targets. Miss them, you lose money, and members don't get the preventive care they need. And HEDIS is important because it drives up the quality of care and in turn improves patient health outcomes. Now, let me make it real with one member's story. Meet Sarah Johnson. Her colorectal cancer screening, or COL, was due on November the 17th. In today's workflow, a care coordinator gets a queue task, manually reviews the charts, chases calls between the member, the PCP, the specialist. That cycle can average sometimes up to 45 days. Now, as you can see, from each of the audit logs from the care management system we use, Sarah completed the screening after the due date. For COL, that is non-compliant for that particular measure year. HEDIS measures improve quality, but they can be operationally very heavy. The member often learns about a gap, or the provider or the care coordinator, they do learn about that gap after it's due. With HL7 FHIR standardizing the data pipes, and with AI on top, we can surface near real-time insights before the deadlines slip. Now, enter our platform. Our HEDIS platform starts with HEDIS but generalizes to any pay-for-performance measure. It ingests HL7 FHIR R4 or FHIR R4 data and unstructured evidence like PDFs and care management notes. We have a Gen AI extraction layer that turns free text into structured proof of compliance, and a predictive layer that flags members at most risk of future noncompliance. Therefore, outreach is focused and fewer calls are needed. Now, if I can speak about the data sources for a real quick minute here, we have made the solution to be input agnostic. Being a health plan and having access to multiple data sources, we're able to take raw HL7 messages, whether they come in MDM, ORU, or ADTs, or FHIR R4 JSON bundles from CDAs or otherwise transformed at the HIE or the Health Information Exchange. In case there is a direct connect for large hospital systems that use EMRs like Epic and Cerner, we also have the ability to take that kind of data in. We also have to we aggregate claims for pharmacy, labs, medications, especially for our layer 2, which predicts the risk of noncompliance. Now let me walk you through this dashboard really quick. We're processing about 1260 synthetic members across 3 HEDIS measures. Only 12 are shown on this dashboard. There's about a 95.3% automated evidence identification rate. That's our Gen AI extraction working. More on that a little bit later once I walk you through the dashboards and the front end demo. The platform found structured evidence for 9 members, and if you click on this filter, let's say you're a care coordinator coming in, you can actually look at all the members for which care gaps were automatically found from their base 64 embedded PDF documents in the raw HL7 messages or FHIR bundles. Now, as the care coordinator comes into this dashboard, they have 2 choices: whether to look at the members whose care gaps were automatically closed because evidence was found in their embedded documents or the various sources that are integrated, onto the back end, or look at the high-risk members right here. So let's start with the members whose evidence was found and pick a member right here. As you can see, this member actually had a recent pap smear completed last month. This was extracted by the NER plus RAG-based evidence extraction engine, and the source was core point integration, where an embedded HL7 message came in. Now, you can also see that layer 2, the risk prediction service, which predicts the non-compliance risk of this member, calls out protective factors because evidence was found and the care gap is actually closed. They have no chronic conditions, they have excellent PCP engagement, and there was a recent normal screening. I wanted to point out the value add here. If this was a traditional workflow, the care coordinator would have to wait for the member to fall into their queue in, let's say, MedHawk Care Prominence, which is the care management platform a lot of the health plans use, and then wait for the manual chart to fall into, again, the MedHawk's backend, review it, call the provider, call the member, compare the notes, log those calls, and then set up a screening, wait for the screening to be complete, and manually close the gap. All of that time lag, which in some cases takes up to 45 days, is completely eliminated by having the solution work in near real time to close that gap and also have a human in the loop. Now let's switch gears to the other side of the coin, where we're looking at high-risk members. Let's say the evidence is not found when the raw messages or the FHIR bundles pass through layer 1 for AI pipeline. Let's pick a member, Robert. As you can see, evidence wasn't found from layer 1, and layer 2, which is our risk prediction engine, calls out a bunch of risk factors. They're overdue for a screening for 2+ years, multiple chronic conditions, high ER utilization. You can set up some patient alerts, you can send an appointment reminder, and we also have a fallback mechanism in case this becomes this is a false positive and there are sources that do provide evidence that this gap is closed. You can still use the manual gap closure button to get rid of this patient from this dashboard. Now, coming over to the provider experience, the clinical decision support for providers. This is intended to be a mock-up of a patient-specific CDS hook. So this is a Smart on FHIR app that is directly integrated into the EHR workflow, and we hope to demonstrate that after you click a CDS hook, what is the landing page looking like for the provider. So as soon as they click the CDS hook, they will land here on, let's say, Sarah Johnson during the encounter or during the follow-up appointment. As you can see, there's clinical evidence extracted from clinical notes, lab results, and also claims data. There's risk and protective factors that are extracted from layer 2, and some actionable recommendations provided right here and called out for the provider, which acts as a clinical decision support. Now, you also have a couple of features like being able to schedule the screening, contact the patient, or update the treatment plan. Now, let's say the provider is done with this patient, they're walked out the door, but he's interested in zooming out to the panel view because they have a large panel of patients, in this case 1,247. They can do so by clicking the panel management view and having a quick view of high-risk patients who are already compliant, and in case you want to drill down into any of the high-risk patients, you can click view details. They can click and go to patient detail to see when is a cervical cancer screening due, if it is already scheduled, and what is their risk factor for non-compliance. Essentially, the value add for the provider is the fact that this surfaces as a CDS hooks card during patient encounters that are real-time alerts at the point of care. And they have access to information by virtue of this solution about care gaps that are not readily available in the EHR systems, which are limited by the data embedded within the EHR. And moving away from the core 2 dashboards and pieces of the front end, I wanted to demonstrate a live processing demo that tracks the end-to-end pipeline of how all of this is happening on the back end, but having a quick view by translating all those logs onto the front end. So let's see this AI processing pipeline in real time. Watch this HL7 v2 message flow through our system. First, spaCy NLP extracts the clinical entities. The LLaMA 3.2 RAG pipeline provides contextual evidence extraction. And finally, the XGBoost Layer 2 models predict non-compliance risk. Each step is a microservice. The HL7 processing in this case is on port 8001, risk prediction on port 8002, care orchestration on port 8003, and they all communicate through RabbitMQ message queues with SSL and TLS encryption. What you're seeing here are logs along with the timeline right here. These are checkpoints created by each and every microservice when they're translated into the queue. And as you can see, layer 1 metadata and layer 2 metadata is sent right here. The care orchestration service actually takes, in the event of a raw HL7 message sent, it takes the HL7 message and translates it into a FHIR R4 bundle. Now, that was for one of the messages, but MDMs and ORUs alike can be processed through this pipeline, as you can see. Furthermore, I wanted to showcase this prototype's potential for production-ready performance. We're currently simulating 1,247 messages in a loop with approximately a 95.2% success rate and an average of 1.2 seconds processing time. The platform handles multiple data standards, HL7 ORU MDM raw files, FHIR R4 CDA bundles, claims, and lab results. The multi-standard processing is key to comprehensive care gap identification. Finally, before I go, I wanted to give you a quick peek under the hood. These are event-driven microservices with Docker Kubernetes deployment ready. It is on Docker right now, but we are Kubernetes ready. HL7 v2 and FHIR R4 processing through AI enhanced pipelines. As you can see, there are 3 core services: the HL7 processing service, the risk prediction service, and the care orchestration service. All these 3 services are facilitated through a messaging queue, the RabbitMQ, and they interact via API gateways and messaging queues. We believe that we are production ready with AWS, Azure, GCP, any of the cloud services, and have compatibility with those, being a microservices architecture. They're auto-scaled by having Nginx, and they have comprehensive monitoring, given that we have a data layer of Redis and Postgre with the ability to cache and store a high volume of messages. And finally, I want to say that security and privacy are absolutely paramount to us. We implement in-depth defense mechanisms with OAuth 2 smart scopes, TLS 1.3 encryption, and comprehensive audit trails. Our AI includes bias testing, model cards, and human-in-the-loop validation. All the demo data is 100% synthetic, no PHI anywhere in the system. Thank you so much for watching our demo. I hope you like it. Take care.